I thank Dr. Vijay Kumar Bada for giving me this opportunity to interact with you all. I specialize in third space endoscopy and I had a special interest in this one. So, endoscopic management for T1 lesions are indicated by ESD. Its ideal size of the lesion should be 10 to 15 mm, not more than 20 mm. And more than 20 mm lesions normally will have lymph node involvement. And deeply ulcerated and depressed lesions are invasive cancers, so they are not suitable for endoscopic management. Imaging studies after histological confirmations are mandatory for staging, whereas when we have 15 to 20 mm lesion, EUS staging is a must to evaluate the depth of the invasion as well as the nodal staging, N1 nodal staging. Options, we have ESD with endoscopic submucosal dissection, ESD along with muscle resection with closer techniques for deeper lesions if patient is elderly, not fit for other modes of management. We also have endoscopic full thickness resection for adherent tumors which are T1. Lesions not suitable for malignancy are the ones which are already fixed and with a deep ulceration. Although this is a second lesion is a T1 lesion, because of the size precludes the endoscopic management. It is 8-9 centimeter in size. This is the picture from 2009. You can see that it is very, very difficult to identify this early gastric cancer in the background of a nodular gastritis. Biopsy only confirms, and we only had 2 needles and clips with loops to manage the complications. And that's how the ESD was done in those days with the picture quality. You can see will keep changing with the newer modalities. Now you can see this latest image enhancing technology where you can see magnification and also zooming. This will show the initial lesion, and if you go near, we can see the surface anatomy of the lesion, and then we can see that there is neovascularization and hypertrophy of the loops, endovascular markers. This actually doesn't need even a biopsy to confirm it is a malignancy. Though technology is advanced so much, we can confidently tell that this is a early gastric carcinoma. How do we manage? Sometimes these slightly ulcerated lesions can also be picked up with early gastric carcinoma. We take about half a centimeter margin from the lesion edge and then give a circumferential incision, then do the submucosal third space dissection by hydrodissection, keeping the plane above the muscles, and then we clear this is the defect, ESD defect, and the lesion is taken out like that. If the lesion looks like this, there is no need for closure, and I haven't had a perforation in 25 years, so that will heal very nicely. Some lesions are very difficult, and if you look at the stages of the ESD, first one will be the marking of the lesion here in the first picture. The lesion is so subtle here with atrophic gastritis, and this is a retroverted view, and we inject the submucosa, lift, and then start the hydrodissection. And then this is the new technology where water inflation can be used to keep the flap up, and then this will be detached in the final stages. And to finish, we have to achieve the hemostasis. And as you can see, this patient had fibrosis. In the fibrosed adherent lesions also can be safely removed by the ESD. When the lesions are difficult to remove and they are not lifting, we use the traction techniques. Commonly used ones are the rubber band and also the spring-loaded clipping, which will give sustained traction. If we inflate the bowel, stomach or rectum, the mucosa will be pulled apart and we will give a sufficient area to operate. We can also use the double channel endoscope to hold the lesion edge and also dissect underneath. This is very suitable for the upper GI endoscopy. Japanese also used magnets, transabdominal magnets, to pull the lesion up. And if the lesion is adherent and it is definitely T1 or T1B, then we can have a full thickness resection as shown in this cartoon. The lesion will be pulled into the barrel of this full thickness device, and you can see the endoscopic image where lesion will be marked, and then it will be pulled into the barrel, and then simultaneous clipping and snaring of the lesion will be done, securing the peritoneal area with the paddle clip. So this will secure and will prevent any complications. Patient can be discharged as a outpatient. Things will go wrong in some situations. You can see that this patient had a full thickness perforation. Nowadays we have dual action clips which can close the defect perfectly, airtight, and this patient did not have pneumoperitoneum next day, and he was discharged after 24 hours. We can also, if we do deeper dissection and muscle level dissection, we can also use the Apollo suture device to close the defect. This will also be useful if we are doing a T1B lesions, and also T2 lesions if somebody is unfit for surgery and very elderly. Thank you for your attention.